Okay, we're going to get started. Welcome to the program. I'm Greg Stone, and it's a pleasure with Antonio Colombo to chair this session titled The Future of Bioresorbable Coronary Scaffolds is Here, the Thin-Walled, High Mechanical Performance Amaranth Medical BRS Program. This session is sponsored by Amaranth Medical, and I think you're going to see some new, exciting developments in the field of bioresorbable scaffolds. So for those of you who are wondering, this whole subspecialty, we believe, is very, very much alive. So Antonio is going to start and give us his session objectives.
Thank you very much, Greg. I have no conflicts. I think the unmet needs of bioresorbable scaffold is optimal deliverability, and I put this as the first because the intervention is still looks for a very deliverable device. Then mechanical properties similar to metal stents. Despite many claims, I think most of the devices available do not fulfill these needs. Fast and complete endothelialization, best guarantee against thrombosis even despite long resorption time. This fact may allow to avoid prolonging the APT time to complete resorption. I think we still don't know if you have to take the APT until the reabsorption. I believe the answer is most probably no, provided the stent is well endothelialized in a reasonable time frame. Thin struts are an essential condition to achieve these goals, and BRS technology evolved with new platform able to guarantee optimal radial strength with strut thickness 100 micron even below. And I really wish BRS technology came into the global market with this requirement and not with the early generation device. Thanks to this feature, BRS performance is matching the one achieved with Metastent, and data will be presented in this meeting to describe this new scaffold, as well procedural imaging and clinical data supporting the attitude. The program of this hour is Juan Granada will present Amaranth BRS technology, current clinical scaffold and experimental insights with small devices. Then Giovanni Esposito, fundamental platform of Fortitude, the first generation device, 150, and Alaide Chieffo, advanced technology, aptitude, 115, and magnitude 98, 9 months clinical updates. And then we'll have discussion, and Greg will give, as usual, his final word. Thank you for your attention.
Great. Okay, so it's wonderful to have my partner, Juan Granada, who's been involved with Amaranth from the beginning, speak about the overall view of the BRS technology from this company, current clinical scaffolds, and experimental insights from the world's thinnest 85-micron BRS.
Thank you, Greg, for the introduction. And I really think Dr. Colombo's introduction was very pertinent for this talk, because I think it's important to understand why the Amaranth technology is different from other PLLA-based devices. So I'm going to try to essentially differentiate both technologies so people can understand why polymer size is important in the development of these future technologies. Typical PLLA resin, an example, BVS, and pretty much actually most of the bioresorbable scaffolds in this field are manufactured by tube extrusion. Then the tube is actually blown up, and essentially mechanical strength is achieved by the biaxial orientation leading to crystallinity. So if you actually imagine this tube, it's got two different domains, some crystalline bridges that actually provides strength, and some amorphous bridges, or actually domains that essentially provide ductility. Then the scaffold actually is cut and then pretty much is crimped. Amaranth is using an ultra-high molecular weight PLLA resin that is very different than the typical PLLA. And the tube is manufactured by layers. So it's a layer after layer after layer, as essentially creating a stainless steel tube, a homogeneous actually tube. A mechanical strength is achieved by the mechanical properties of the material, not by any type of crystallinity bridges. Then the scaffold essentially is cut, and then that's the reason why the final product actually is manufactured. So one important difference is, if you can imagine, these crystalline bridges had a limitation for expansion. This actually tube provides a more potential for essentially ductility and also fracture resistance. So let me just show you a difference in which right here you will see the typical PLLA resin. Here you're going to see the ultra-high molecular weight PLA resin. This is what the engineers call elongation at break. An elongation at break is a way to essentially test ductility, or the ability to essentially stretch, and actually strength, which is the resistance to essentially to fracture. Typical PLLA has around 4 to 6% elongation at break. Amaranth actually has 120% elongation of break. I have shown this actually before in numbers, but essentially people essentially believe when they start actually seeing this. So this is typical PLLA snapped. You actually see here the Amaranth polymer going all the way to actually 120% of its original structure until essentially finally breaks. So this is extremely important biomechanically, if you can imagine. Amaranth right now is the only company that has been able to progressively go down on the straw thickness to 85 microns. And it's been actually a very interesting program because it has followed a biomechanical process, an in vivo process in animals, and also in first-in-human clinical trials. You actually see the Fortitude going from 150, Aptitude 115, Magnitude 98, and the new Defiance, which is 85 microns. What we don't typically hear from companies is when you actually go thin and you go small, with typical PLLA, there is some type of trade-off that you have to essentially give up. And most of the time what happens is essentially the footprint gets larger. One thing that I want to highlight is that actually from Fortitude to Defiance, essentially the footprint of the device has not really dramatically increased. It's been actually maintained pretty much stable. Also, overexpansion above nominal. You guys remember the 0.5 millimeter rule for BVS. Right now, these devices can actually go up to 1.5 its nominal diameter, which is a great feature for the interventionalist. So what are the characteristics that are important for these devices Dr. Colombo was talking about? The first thing is preservation of radial force below 100 microns. All these devices with typical PLLA, when they actually start getting around 120, 100, you start losing radial force. You see here the typical radial force of absorb, the typical radial force of a metallic stent, and you see that all the Amaranth devices are above this number in terms of the capability to expand and essentially overcome the resistance of a vessel. Another characteristic that is extremely important is fracture resistance following overexpansion. You see all these live cases, post-dilatation sometimes occurs in a very aggressive manner. And you see here a comparison between Amaranth Aptitude, the 115 versus Absorb. You see here the resistance of these material essentially to be expanded. You see here right now when you pass the 1 millimeter threshold in BVS, it starts unzipping. And you see here Amaranth essentially going all the way into a significant overexpansion with a 5 millimeter balloon. So typically all these devices on Amaranth, you can actually go up to 1.5 millimeters above nominal before you see the first fracture. And you see here up to 2 millimeters just to see the third fracture. So very durable when it comes down to expansion. But it's not just about radial force, and it's not actually just about fracture resistance. One important characteristic is resistance to fracture under cyclic conditions. So imagine if you put a device to essentially in a cyclic machine and you essentially test for fractures as time goes by. So this is the number of cycles that essentially you can translate into time. And you see here the different devices from 157 to 85, Aptitude, Magnitude, and Defiance. And again, you see 0 to 5 fractures essentially pretty much occur very late compared to Absorb. So these are very durable devices, not only in the implantation procedure, but also over time. For me, this is something that is going to define the field, and Greg and I have talked about this a lot. Mechanical integrity over time, more than actually at time zero, is key to maintain a strode-vessel contact while polymer resorption occurs. I am not a believer of fast resorption. I really think the durability and the structure of the device while it gets resorbed is extremely important characteristic. This is a comparative long-term in vivo mechanical stability study that we did in the experimental level in all the devices, including BVS as a control. This is a percentage of late recall, as you can see here, essentially calculated by OCT, essentially looking at the area of the device over time. And you see that absorb, and this is actually very reproducible. It's got a certain level of recoil, around 6%, that happens in 28 days, and I'm talking about normal arteries, that remains essentially over time up to 180 days. You see on Fortitude, aptitude, magnitude, pretty much the lumen area of the device remains stable over time, and this is actually data that is going to be presented clinically with OCT data in humans as well. Another important characteristic is the impact of a strode thickness on molecular weight loss and polymer resorption. You see the typical curve of BVS. You see actually for Fortitude, 50% of molecular weight is lost in approximately 10 months, and then you see 85% is actually around 18 months. One thing that is interesting is the overall resorption profile doesn't really change because the polymer is the same. But what happens is when you have less volume, less mass, pretty much the overall resorption time decreases. So you see here now the curve for aptitude getting shorter, and now then when the curves are calculated for magnitude and defiance, the curves are going to be essentially lower in terms of the time of total absorption time. This is actually some of the data presented before, vessel healing and remodeling at 4 years by OCT. This has been a very comprehensive experimental study, going down from 157 right now to 85. Longest animals now have been followed for 5 years, and this is actually an interesting thing. A lot of histology has not been done because essentially these animals continue to be followed over time with longitudinal imaging. But all this data down to 100 microns already undergoing, and it's a device that is being validated experimental level right now into the 98 micron device. This is perhaps one of the most important things, especially on the stent thrombosis issue, and is the impact of a strode thickness on a strode coverage, which we typically do in either rabbits in iliacs or in pigs at 14 days to see early healing. And you can see here that from BVS to magnitude, the percentage of embedded struts starts to essentially increase when you go thinner. And you see the number of actually uncovered struts start to go down when you actually go thinner. So this is actually very logical, but it's extremely important, especially because we know that the main issue that BVS essentially had was the stent thrombosis rate. This is actually part of the pictures of a study that was recently completed. You see the Amaranth 85 micron device at the experimental level versus metallic DS that has comparable strode actually thickness. And it's actually amazing just to see now a strode thickness at the level of 85 microns that are highly comparable and very similar to a metallic DS. So this is actually really a reality. So the next speakers are going to talk about the clinical program, and I'm not going to actually present any other data, but just to show how responsible this program has been, essentially going all the way from a small first-in-human that included a bare scaffold all the way down to the magnitude program with actually more complex lesions, up to 2 lesions to the 98 micron, and then follows with the defiance at 85 microns. Around 206 patients have been enrolled, and a very important piece of data is the aptitude 115 micron. Already 68% of the patients have achieved 2 years, which I really think is the longest follow-up for a device below the 120 micron range. I only want to present one slide that I want you to pay attention throughout all presentations, and for me this is actually something that I believe is going to define the bioresorbable scaffold field, and is the stability of the scaffold over time, the ability of the scaffold to stay contained, maintain the stent areas. It happens with metallic stents as they absorb. And if you see in all the trials from 150 to to the 98, this is a still small sample because still is collecting the data, you really see the stability of the scaffold up to 9 months. After 9 months, it doesn't really matter as long as the device is essentially fully covered. The future is here. You see one of the pictures of the 98 micron device in humans. And again, you know, I'm very excited when I see a device that already has a wall thickness similar to metallic DS, and they start to look like metallic DS at 9 months as well. So in conclusion, the clinical success of the BRS field depends on the development of thin strut, less than 100 micron scaffold displaying DS-like performance. The Amaranth BRS technology has progressively miniaturized its BRS platform to 85 microns without compromising biomechanical performance. Experimental data has already validated the biocompatibility, mechanical behavior, and healing response down to this strut thickness range. A careful stepwise clinical program in terms of strut thickness is undergoing to investigate the impact of strut thickness reduction in clinical performance. And human clinical studies support that below the 100 micron threshold, the Amaranth BRS technology exhibit DS-like performance in regards to angiographic restenosis and strut healing response. Thank you very much for your attention.
Thank you very much. I think we leave the discussion at the end.
Well, I think we're supposed,
Oh, yeah, we
according to
can
this,
leave
we
it.
can have a
Okay.
little discussion. So,
Yeah.
so Juan, if you want, you can join us up here or stay up there. But you know, so maybe I'll start. So right now we're talking mainly about the physiochemical properties of the scaffold and the material. I mentioned in one of the other rooms I was at that tomorrow I'm going to be giving a kind of a redux of what we've learned from the Absorb clinical program. And we saw kind of 3 unique failure modes. We saw acute fractures, we saw in occasional cases chronic recoil, and then what you and I described as intraluminal scaffold dismantling. It certainly seems that the improved ductility with this device is going to almost eliminate the acute fracture problem. Chronic recoil will hopefully be seen much, much less. But what are your views about what the properties of this device might do to what is now the most feared complication of BRS, which is this late bulk erosion process leading to some irregular components translocating into the lumen and being a nidus for thrombosis?
So, you know, at the very beginning, we were all excited about the concept of something disappearing very quickly. But I don't think that we took into consideration that this is a fight between the injury caused by the procedure, plus the healing response, which usually happens, so negative remodeling, plus the absorption of the device. So one of the things is, and at least this is my perspective for bioresorbable scaffolds, I would like a scaffold that maintains mechanical integrity until healing response is almost at the time in which is completed, 9 to 12 months. Dismantling is not really a problem as long as the device is opposed and as long as the device is fully covered. So if you can actually maintain the vascular integrity, architecture, until the peak of restenosis essentially occurred, I really think that's the type of mechanical attribute that we need to look for. For that, you require a device that is strong, a device that maintains, you know, the lumen, and actually a thin strut, so actually covers very quickly.
So do you have any insights into when in the time course of molecular weight decrease you'll start seeing some breaks in the scaffold in its natural history, which occurs with every scaffold that bulk erodes? Do you think that's going to be 1 to 2 years?
No, so if you look at the molecular weight loss, in the 150 and the 115, which is the data that is available, 50% of molecular weight is actually lost in approximately 10 to 18 months, according to the wall thickness. That's actually the time that you need to keep the radial force. So, I mean, I don't think it's, we don't have enough data yet. I think some of the OCT clinical data is going to show that. But the incidence of dismantling at 9 months in this device that is being reported by Core Lab, and this is work that is still going, is extremely low. And BVS was around 43%. And this device is actually, yeah, for the dismantling at 9 months. And
yeah, it's an interesting phenomenon. I don't know if this is the right forum to discuss it, but you know, with bulk erosion, you have the polymer dissolution occurring equally from the outside and the inside. And you would think it would be uniform. And as long as the strut thickness is pretty much the same everywhere, you would expect you wouldn't be getting these breaks. Although I presume there are some differences in the mechanical stresses, et cetera, at different hinge points, et cetera. So I do think that it's going to be very important with, for example, in this case, the very high molecular weight PLLA may make a difference in how the scaffold breaks with different stresses over time.
So this is I have actually some picture didn't include. This is a very important difference between highly crystalline polymers and polymers that are highly amorphous. In the crystalline polymers, it's actually very difficult to essentially predict where the crystalline domains are going to be in relationship to the design. So those actually stress areas that you're talking about are seen. Once you expand, for example, a BVS, you see these lines of potential long-term failure. Because this is a very ultra-high molecular weight and is actually homogeneous, those stress lines are actually not that apparent and actually do not occur in that frequency.
But the key to success, to overcome whatever dismantling will occur, is complete endothelization, and the scaffold has to become part of the vessel wall. Then if it breaks in one way or the other,
matter, right?
it's
Then you
already
don't care.
part of the vessel wall. Fortunately, with metastent, this is not a requirement, because even if it's not part of the vessel wall, the device is going to stay the way you leave it. So we hope that this integration will be facilitated by thin struts.
I agree.
So
And a good technique.
and should be. I mean, we tried to overcome the thick struts limitation by very, very high pressure implantation. So the most easy way to make a thick strut thinner is to embed the strut.
Exactly.
But not always is possible. If the wall is fibrotic or calcific, you cannot embed the struts. So
Or you have recoil.
so we hope that these. I think there are all good reasons to believe that thin struts will facilitate endothelization.
Oh, absolutely. So Juan, what's been your experience histologically with inflammation with this particular PLLA? Some pathologists say that PLLA is associated with a moderate to even more inflammation. Other people say it's got a relatively low background inflammation. All polymers, as they're bioresorbing, have some inflammation. What have you seen with this one?
The comparative data, and that has been published for BVS extensively as well, and it's the same thing for this device. The inflammation and background inflammation is comparable to science. What actually changes is time, because as the resorption time
Right.
actually occurs, in metallic DS actually peaks and then remains stable. And this one actually continues a little bit longer, but is not really excessive enough to produce more neointimal proliferation than any other metallic DS.
Yeah, the pH changes not so
Exactly.
much
Exactly.
from the lactic acid accumulation. So one other comment I would make and ask you about is what you think the implications will be for bifurcation treatment. So what is the strut width? We always talk about thickness. We don't talk that much about width. So what's the width of all the different devices, and what will be the implications of the ductility and expansion characteristics on bifurcation treatment?
Yeah, no, this is a very good question, Greg. And honestly, I don't have the specific number, but if you look at the footprint of the surface area from metallic DS, about 18%, 16 to 18%. Here is around 22%. So the width is not really as different, even though it's a little bit wider because it's actually required. I also have a picture I didn't include in which we show the dilatation of the scaffold through one of the strut cells. And actually, you look at the deformation. You see the deformation of the polymer essentially staying DS-like. So this is one of the properties that the material will allow you to do side branch dilatation. And I'm not really talking about two stent technique and things like that yet, but
Right.
at least in terms of going through a side branch and
Yeah,
dilating
and
through the
using a
polymer.
3O balloon and even larger,
I
you would
think that
hope
would be
that
possible.
would not break.
So one final question. When, I believe sooner or later you will design a study of these devices in complex lesions. or in lesion more long lesions, etc. When you will propose this study, the DAPT duration, how long will be?
With a thin strut scaffold, I don't really think there is any reason to believe there should be any different than a metallic DS.
So will be 1 year, 6 months?
Yeah, according to the patient population that is going to be included. If you're talking about 98 or actually 85 with a good technique and imaging, if you do imaging and you confirm the struts are fully opposed, I don't really think
let's say, because, you know, imaging is not, you cannot propose to the general community to use imaging all the time. So when will be time to implant these stents, 85 micron, let's say that works well, in the cath lab as a regular stent? For how long will you recommend DAPT?
I was hoping that you would help with that question.
Well, actually, let me help with that. Let me help with that question. Let me help with that question, because I don't think we should repeat the same mistakes that we made with Absorb. And I don't think with new scaffolds we should be getting into complex, diffuse, calcified disease until we've learned that we have adequate safety with less complex. And I think that the safe and prudent approach is actually prolonged apt until, whether it's a thin scaffold or a thick scaffold, you can still potentially get intraluminal scaffold dismantling because you'll have inhomogeneity of tissue coverage, et cetera. So until we really learn more about this, I think going into the next series of experiments, we have to err on the side of
prolonged
safety.
app, how long is it?
You know, for me, it's 3 years.
3 years.
It's 3 years. In the patient at low risk for bleeding and whom the, you know, ischemic
So you
hemorrhagic. I'm going to be safe.
Currently, you will implant these devices in maybe 20,
AB1 lesions.
20-30% of the patients.
I think that's, for the early experiments and comparative experiments, I think that's prudent, yeah.
Okay.
For all the new generation scaffolds, not just Amaranth.
Okay.
Great.
Let's
All right.
continue.
Terrific. So that was fantastic and great discussion. So now let's look at some of the data and some of the imaging outcomes, and we'll start with the foundational platform, which was the original Fortitude 150 micron device, looking at the 2- and 3-year clinical update, and this will be presented by Giovanni Esposito.
Thank you, Mr. Chairman. Good afternoon. So the first, the Amaranth BRS clinical program included more than 206 patients, and I'll be talking about the first generation platform that was the Fortitude, with the strut was 150 micrometers. And right now we have, in the Fortitude program, we have 63 patients in which the complete follow-up is completed at 2 years, and there is an ongoing follow-up at 3 years. The Fortitude sites and the study design included was a perspective randomized multicenter single-arm study that evaluated the safety and the performance of the 150 BRS, and the lesion were de novo epicardial lesion with the length between 14 and the diameter going from having the scaffold from 2.75 to 3.75. So these are some of the characteristics of the scaffold that have been already discussed, and so the wall thickness is 150, and this surface coverage area at RBP was 20%, and the scaffolding was the bioresorption time was at 95% reduction at 18 months. So this is mainly the characteristic of the device. And the study of the Fortitude device was actually based on the angiography with the patient that were undergoing all of them to the predilation, and with the target of minus than 40% stenosis following the predilation. And the scaffold then was implanted with the optimal angiographic result that, if not were obtained with the release of the stent, then was a mandatory post-dilation with the and a non-compliant balloon. And then after the implant of the BRS, there was a OCT scan that was then at 9 months repeated with an angio, and at 2 years also was a follow-up with angio OCT or a CT scan, and then at 3, 4, and 5 years there were clinical follow-up. So these are the characteristics of the patient. Mainly, all patients were intermediate risk patient with 32% of patients with diabetes, 60% of smokers, and more than 80% with hypertensive patient. And 40% of patients almost have a previous MI and history of PCI in 60% of the patient with the preserved ejection fraction. And the distribution of vessel treated were almost homogeneous between LAD, circumflex, and RCA. And as you can see, the lesion were B1C type lesion, so complex lesion, with moderate severe calcification, only few patients, because this was a criteria of exclusion of when heavy calcification were present. And actually, the device success was the clinical device success of this program was 98%, as you can see here, and the clinical procedure success was almost 97%. So this is the QCA data that you can see here, and very interestingly, as you can see at 9 months, the late lumen loss was 0.17, and the in-scaffold analysis at the QCA showed a 0.29 late lumen loss. And as you can see, also the cumulative frequency distribution at 9 months of in-scaffold late lumen loss was very homogeneous distributed. And here you can see the OCT measurement, in which you can see how the so the integrity of the scaffold was preserved at 9 months, going from 7.72 to 8.08, and the percent of opposed the percent was 98.3. So this is very interesting data of the integrity of the scaffold, the position of the scaffold itself. And if you see the 9-month safety endpoints, also in this case, you can see how there was a target vessel failure of 4.9% with only one non-cardiac death. And also there was a peri-procedural asymptomatic enzymatic raise of actually in 2 patients. And also the ischemia-driven TLR was one patient with 1.6% treated with the PCI, with 0% of thrombosis at 9 months. And when you see the QCA at 2 years, as you can see, also the late lumen loss was preserved at 2 years, going from 0.17% to 0.15%, according to the in-segment analysis. And also in the in-scaffolding analysis, you see a late lumen loss going from 0.29 to 0.27. So still the results that we gained in the beginning were preserved up to 2 years analysis in 30% of a patient. And this is the 2 years OCT measurement that was now obtained in 19 patients. And also, as you can see, still the mean outer scaffold area is preserved, so the integrity, also OCT measured with OCT, is still there. So at 24 months, you can have you see a mean outer scaffold area that is going from 7.96 to 8.46 and 8.47. So still the integrity of the scaffold is preserved up to the 2 year of analysis. And also, very interestingly, the percent opposed per patient, the total opposed per patient is 98.9. So this is a very good result that has been shown for in the OCT. And we have also an interim analysis at 3 years. This is in the safety endpoint, as you can see here, the clinical results that were obtained are still preserved at almost 3 years of analysis, in which only there is a new TLR that basically were driven for with a overdue to a patient that stopped all medication at 24-month follow-up and 8 days before the event. So still the result, the clinical results as 24 months and 36 months are preserved. So this is a few of the images, OCT image and angio from the 150 scaffold that, as you can see here, there is a good result post-implant, and at 9 months is preserved, showed by the angio and in OCT images in all segments treated, showing the integrity of the scaffold at 9 months. And also at 2 years, as you can see, there is a good healing of the vessel with the integrity of the BRS following 2 years of follow-up. So, in conclusion, the safety and clinical performance of the Amaran Fortitude under 50 micrometers BRS was demonstrated in this international multicenter study, in which a high clinical device success rate was obtained with 90.4%. With the low MACE rate at 9 months, one safety endpoint of 4.9, 2 periprocedural MIs and 1 non-cardiac death. And still at 2 years, you have 3 additional TRS, including 1 ST due to the medication interruption of the patient. And we have also a 3 years interim analysis that show only 1 additional non-cardiac death. So, as the endpoint of efficacy is still preserved after 9 months, as you can, and that going from 0.29 millimeter in scaffold late lumen loss, that from 0.29 goes to 0.27 at 2 years, and still is maintained. And the sustained effect of the anti-stenotic property of this scaffold is maintained after 2 years with 88.3% of restenosis, showing also an almost complete stat coverage in 96% of patients with biopsy analysis at a month. So, the imaging that we showed, analysis out of 2 years, show that the Fortitude platform continued to exhibit mechanical stability, strata position, low restenosis rates. So these 3 years data suggest that the Fortitude BRS represents a solid foundational platform for the future development of thinner star scaffold that we will see in the next presentation. Thank you for your attention.
Great. So maybe because now we are into the clinical data, maybe instead of discussing now, why don't you join us and let's hear from Aleid Kiefo next, who's now going to talk about the advanced technology platforms, the Aptitude 150 micron and Magnitude 98 micron 9-month clinical updates.
So, dear Chairman, dear colleagues, my topic today is to show you the 2 studies with Aptitude 115 and Magnitude 98. So we will, in the same presentation, present the clinical data and the clinical program from these 2 different devices. I mean, we have to congratulate actually to the company to be able in such a short time period to develop so many different evolution of the device. We have seen before the 150, then they came out with the Aptitude 115, and finally in the Renaissance 3 with Magnitude 98 micron. It's the same kind of platform and polymer, PLLA, just going down with wall thickness, surface coverage area at RBP, also going down with the wall thickness was maintained at 22%. Drug content was a little bit different, 95 to 160 microgram in Aptitude, 97 to 144 in the Magnitude. Both of them were 6 French compatible, and we were able to deliver them by radial access. The program, it was introduced before the Renaissance 1 with 150 and Fortitude. Indeed, we will speak about the Renaissance 2 with Aptitude 115 micron and the Renaissance 3 with Magnitude 98. In the first, there were enrolled 60 patients. In the second study, 70 patients. Angio-OCT follow-up is ongoing 2 years in the Renaissance 3, and indeed is ongoing 9 months in the Renaissance 3. The countries were the same, again, Italy and Colombia, and the sites were the same as the site mostly of the Renascent 1. The design of the study is similar. It's a prospective, non-randomized, multicenter, single-arm study evaluating Renascent 2, again, the aptitude with 115 micron, and the Renascent 3 magnitude with 98 micron. The endpoint, primary endpoint, was the same, TVF, and late lumen loss at 9 months. In the Renascent 2 and 3, the population is still a classical population of a Precimark study. However, it was possible to treat more than one lesion, so it was up to 2 de novo epicardial vessel lesion, even if the lesion length was limited to be equal or less of 14 and the diameter between 2.5 and 3.7. The design of the study 2 and 3 are similar to Renascent 1, so clearly the patient had to meet the inclusion baseline clinical characteristics. Normally they were stable patient, or if they were acute coronary syndrome, they were troponin negative. However, the choice was made based on the angiography and the lesion length, and after the angiography, it was mandatory to have a baseline IVUS. And according to the IVUS and the vessel size measurement and the absence of severe calcification, the patient were entered into the study if they had a vessel size between 2.5 and 3.7. It was mandatory predilatation, followed by scaffold implantation. Again, the scaffold size was decided upon the IVUS measurement. And if the operator considered only by angio at this time that the result was suboptimal, it was possible to perform a post-dilatation. Indeed, if the operator by angio thought that the result was optimal, they could go to the final OCT post-deployment. By protocol, it was required to have a 9-month angio follow-up with OCT, and by protocol, a 2-year. The patient could have been studied by angio or also CT angio follow-up. Clinical follow-up will go up to 5 years. Clinical characteristic, again, this is a classical Precimark study, so the patient normally have quite a low clinical profile according to the usual risk factors. In fact, medical treated diabetes very low, only 18% or 14%. Mostly they were stable presentation in Renascent 2. In Renascent 3, there were more distribution of acute coronary syndrome, but again, these are not ST elevation MI or troponin positive, is unstable angina with troponin negative. LVF preserved. Also regarding the angiographic characteristics, mostly they were treated LAD, was the target vessel, and in most frequently proximal and mid lesion. Reference vessel diameter in both studies was 2.8, but there was 20% in Renascent 2 and almost 15% in Renascent 3 of the patient that had a reference vessel diameter less than 2.5 when QCA was performed. Normally, lesions were quite simple lesion. The bifurcation actually were excluded from the study. So the investigator were asked not to include the patient who had bifurcation with a side branch that could be stented or big enough to be stented. In fact, if 5% had the bifurcation in Renascent 2. Regarding the Renascent 3, it was described to have a 40% of any bifurcation, but actually there should have been bifurcation where the side branch was not big enough to be treated. Moderate and severe calcification only in really minority on Renascent 2, 10%, but indeed in the Renascent 3, maybe the operator was more confident dealing with a thinner BVS, 22.9% of the patient had the moderate to severe calcification. Regarding the procedural implantation endpoints, as we said, it was mandatory to do a predilatation, 100% in Renascent 2, and almost all patients, 73 out of 74 in Renascent 3. Post-dilatation, and I think this was quite interesting, it was performed in the majority of the patients in Renascent 2, was 76.7, but indeed post-dilatation was performed in a minority, only 23% of the patient in Renascent 3. The maximal scaffold deployment was almost the same, 11 and 13. failure to cross due to severity in 2 patients in the RENASCENT 3 study. And clinical device success, very high, almost all patients, 59 out of 60 in RENASCENT 2 and 72 out of 74 in RENASCENT 3, with high clinical procedural success, 100% in RENASCENT 2 and 97.1 in RENASCENT 3. 9-month angiographic analysis, we tried to put together the 2 studies. Maybe the slide is a bit full and not easy to follow, but just to show you that actually this kind of platform and device, what we have seen in RENASCENT 1 was kept in RENASCENT 2 and 3, in the sense that MLD almost was maintained, post-BRS up to 9 months of follow-up in segment, in scaffold. No restenosis were observed in RENASCENT 2. In RENASCENT 3, also there was almost kept the MLD in segment from 2.5 post-implantation to 2.3 and 9 months. And late lumen loss was 0.19 and 9 month follow-up in RENASCENT 3, and indeed in scaffold 0.31. Very similar to RENASCENT 2, that a 9 month follow-up was 0.19 at in-segment analysis, 0.33 at in-scaffold analysis. Binary restenosis in the RENASCENT 3, there were 3 cases of restenosis. What about 2 years? Clearly this is an interim analysis because not all patients got the 2-year endpoint in RENASCENT 2. And then there was this mixture of angiographic follow-up and coronary CT scan. So we are talking about only 10 patients that had an angiographic follow-up 2 years, but again, there is stability of the scaffold, the MLD is maintained, and late lumen loss from 0.19 to 0.30 at 2 years. And in scaffold, it was going from 0.33 to 0.34. And there was no restenosis, as we have said, in 9 months. Indeed, at 2 years, there was 1 patient with restenosis. Clearly, this is not all the study population. Regarding the CT angio analysis, it was detected 1 restenosis at the CT skull. Clearly, this patient then underwent to angio follow-up and revascularization. So the coronary binary restenosis, combining the angio and the CT scan, there were 2 patients out of 25 that achieved the timeline with restenosis. Regarding the OCT measurement, RENASCENT 2 in comparison with the RENASCENT 3, regarding the mean outer scaffold area that was described before, just as a sign of stability of the scaffold, from 7.8, it was kept at 7.83 at 9 months in the RENASCENT 2, and it was similar also in the RENASCENT 3, because the mean outer scaffold area was from 7.8 to 7.9. Regarding indeed the percentage of apposed thrusted per patient, it was post-BRS 96%, in total 99.5 with the RENASCENT 2 and 99.4 with the RENASCENT 3. Interim analysis regarding RENASCENT 2 of the clinical follow-up. So far, there was no patient who had the target. There was 2 patients at 9 months with target vessel failure, no patient from 9 to 24 months, and there was actually no patient with stent thrombosis. And this is quite reassuring. Clearly, we don't have all the patients at 24 months and the sample size is small, but to have no stent thrombosis with this platform is something that is reassuring for the clinician. Regarding the RENASCENT 3, again, we have the data of the interim analysis of the patient, 48 out of 70. So far, there were 2 target vessel failure in hospital. There were 2 target vessel MI. This was due to periprocedural asymptomatic cardiac enzyme elevation, and 1 case that was due, that was again cardiac enzyme elevation. It was thought that this was due to some air embolization during OCT or some complication. However, the patient was asymptomatic and there was no clinical consequence of the rise of the enzymes. So the TVF were mostly driven by non-Q wave and pre-procedural enzyme elevation. There was indeed one patient who had ischemia-driven TLR. We remember that were actually 2 restenosis, 1 was treated. And again, with the Renescent 3, there was no stent thrombosis up to 9 months follow-up. This is a case of magnitude that was done in our lab. Clearly, this is a young patient, 46, with the usual coronary risk factor coming with stable angina. You see the image pre-PCI, the image post-implantation, and close to that, the OCT analysis. It was jailed, the septal branch, there was patent. Distal edge, there was some minor malposition, but no dissection. And on the right, you have the 9-month follow-up. The MLA was 6.36 as compared with 7.25 post-procedure. The septal branch is still patent, no tissue bridging. And the distal edge, there was a resolved malposition and no intimal coverage. So in conclusion, the Renascent 2 and 3 studies are international multicenter studies that evaluated and are evaluating safety and clinical performance of Amaranth Aptitude 115 and Magnitude 98 with high clinical device success rate, low miss rate, angiographic in-scaffold late lumen loss at 9 months of 0.33 and 0.31 at the interim analysis respectively, sustained anti-restenotic effect up to 2 years, and what was interesting was the nearly complete strat coverage, 97% by OCT analysis. 9-month imaging and interim 2-year safety analysis indicate that this next generation BRS seems to exhibit mechanical stability, as we have discussed through the presentation, strata position, and low restenosis rates. Thanks for your attention.
Okay, so we have maybe about 8 minutes for a quick discussion.
If you can stay there.
Yeah, if you can. Sorry, we have a small table.
Yeah, you can stay there.
So I know, Elaide, maybe I'll speak to you, and Antonio, you've done a lot of these implants. Obviously, these are relatively simple lesions and simple cases, but as you've gone down from 150 to 115 to 98, have you felt a difference in deliverability and in catheter performance?
I think that the biggest difference you see also from data, the post-dilatation, that was interesting. Yeah. The post-dilatation went down. I mean, the latest version, it's only 20% of the scaffold were post-dilated. So it means that we were happy angiographic, because you see the protocol said that you have to have your endpoint achieved by angiography. So if you think angiographically it's fine, you stop and you do OCT, and maybe you can take some action by OCT, but theoretically OCT is the last action you do. If not angiographically, you do post-dilatation. And the fact that only 20% of the 98 were post-dilated, I think it's a mixture. It's a mixture of the performance of the device and maybe also the operator that feel confident with a thinner strat not to go to further post-dilatation.
Do you, Antonio, do you want to make a comment about how this feels compared to a metallic DES?
But, you know, I personally disagree on not doing routine post-dilatation. Because a requirement for these devices in order to make reabsorption safe is that the struts are well covered. A metastent, even if you have some minor malposition, should be inconsequential unless it's really dramatic malposition, because the malposed strut is just going to stay where it's there. If you have a malposed strut in any BRS, the struts will start hanging around. Of course, if it's thinner, the hang around is less consequential, but still is not a pleasant event. So the best reassurance to avoid even minor malapposition is routine post-dilatation. The way to overcome this routine post-dilatation, which is a pain in the neck for many people, is to place this device on relatively high pressure balloon. So you deliver the scaffold at 15, 16, and you go up to 20 atmosphere, and that's your routine post-dilatation is taken care.
But as you know, but it's
Yes.
really, it's got to be a high-pressure, non-compliant balloon.
Not, you know,
Because otherwise you get the dog boning.
even low compliance. I mean, current, new generation DS, we deliver them at 18, 20 atmosphere.
But there is one thing, and Greg actually the other day put out a very convincing argument for post-dilatation in all the cases. But we have to remember one thing, and just to emphasize what Elida said, is that this was a study in which OCT was done in all patients following implantation. And then if the operator would see either malapposition or a lumen device area that he didn't think was appropriate, then he would go ahead and actually do post-dilatation. So, I mean, it's very difficult to argue when somebody says, my MLA is optimal and all the struts are opposed. You know, why am I going to post-dilate when you have a big lumen and all the struts opposed? So that's actually, I think, the message is not about against post-dilatation, which actually I agree with you in bioresorbable scaffolds is important. It's just the fact that the mechanical strength of the device allowed to get away with it in a lot of the cases.
Although
But then you have the OCT at 9 months now.
Yeah, that's what I'm
I mean,
saying.
it's an
Right.
interim analysis.
98% strut apposition, so.
Yeah,
So maybe they did a good job.
So, I mean, I think that, again, this leads to a long discussion. As we were saying, the post-dilatation has several advantages. It drives the strut somewhat into softer tissue, so it embeds it. That's point number one. 2, it makes sure there's no malapposition. And 3, it may actually induce a little bit of neointima, which is a good thing to get some coverage over the struts. So when you get the bulk erosion process, you're not going to have intraluminal scaffold dismantling. So I think also what these operators accepted as an OCT result is probably very different than, for example, in a Lumion 4. What we're going to be accepting is an acceptable result. What looks like a round circular lumen often doesn't have an optimal stent area. But let me ask you one question, which I think is interesting, is that Antonio and I were commenting on it. The angiographic results are good. The percent volume obstruction is at 12 or 13% is quite favorable at 9 months. The late lumen loss seems a little high compared to that at around, on the average with the 3, it averaged around 0.3 millimeters, and it didn't seem like it was going down from the 3 devices. Any comment?
So a couple of things. I mean, number one is very small sample sizes. And the thing is, if you actually look, you have 3 restenosis cases and essentially skews the data completely. On the 150 is interesting. If you look at the data with or without restenosis, the angiographic late loss remains very similar, 0.29 or 0.3. On the 115 and in the 98, it starts to change. Like, remember that it's only 40 patients with angiographic follow-up, 48 patients, 38 patients, something like that, in the magnitude in the 98. If you take those few restenosis cases out, the angiographic late loss in a scaffold, the distribution is 0.19. So, I mean, the trend is actually there. I would love to see the data with actually a larger population. But I think one thing that you and we have talked about this, and also is increasing the footprint of these devices, is going to slightly increase the angiographic late loss. I mean, that's.
But here at 20%, surface area coverage is pretty low. I mean, absorb, is closer to 32, depending on the size. When you put it in a small vessel, it was closer to 40. So, metal DS is around 14 to 16. So at 20 is not bad coverage.
And one thing that is, at least for me, intriguing, Elida showed this on the 24-month, the few patients that actually had angiographic follow-up. I mean, actually a handful of patients. The interesting thing is the angiographic late loss remained stable.
Yeah, no, that was very clear. So I think it's very impressive that there hasn't been a stent thrombosis yet, and that's important to see. Do you have any insights from imaging into the 2 cases of restenosis? What did you see in those cases? Was there anything unusual?
I mean, that were not from our.
Okay.
I mean, mostly.
Of course not.
Maybe one.
Of course not.
We had But mostly, I mean, I think
they
that
did
one
happen
of
in
the one of the repeated revascularization actually was due to not full lesion coverage.
Yeah, the one was
That's
an edge.
one of the
Yeah.
problem was the edge, because you have to remember that the lesion length was really limited to 14. And I mean, there were some cases that we were unlucky that we had progression of disease, because this can happen. And it was in the Renascent one, so the two cases actually were you have also some target vessel related MI that were progression of disease. And some of the restenosis actually were edge. I mean, I don't know all, I didn't review all the cases.
So let me ask, maybe I've got to close because you're closing here. Juan, I want to ask you one more question. So we've gone 150, 115, 98. Now you've got the 85 micron Defiance program. Okay, are we going to see a 62 micron Amazement program? Are we ever going to stop? And so what are the future plans in terms of getting into larger numbers of patients, randomized trials?
Then I cannot really speak for the company in terms of, the future, I mean, how low you can go. But, the one thing that we all need to understand is there is a limit for the type of material companies are using. Which is very encouraging, is that 85 microns biomechanically and at least in the early experimental data, it seems to maintain the mechanical strength and durability. I would say 85, at some point now, this needs to jump into a randomized study, large study, and, to prove clinical outcomes. And I really think anywhere from 85 to 98 is good enough, I would say, to compete. I know that you lately been talking about the 60 micron range, but I really think that we need to prove first the bioabsorption process is safe, and you have a stent thrombosis rate that is comparable to metallic DS before jumping into next generation. And I would say 98 is already pretty impressive.
One question that has not been asked, what about visibility of the scaffold?
Yeah, I mean, the visibility of the scaffold, it's not mostly different between the other scaffolding, PLLA. And what is actually very different between the three scaffolds that have been released is the ability to reach the distal lesion. That is something that we didn't talk here. So we noticed that it's much much easier to go compared to the first 150 micrometers scaffold. Using the latest one, it was very easy to going down even in the moderately calcified vessels. It was very easy, and also the markers helps you to localize very well where to position, and I think it's something that will. It's also an issue. I mean, if you have to go down with the struts, with the thickness of the struts, I think when you reach enough the thickness that the stent is able to go down, I don't think, and the vessel heals very well. I don't think then you have a good. I mean, you don't need to go further down, because you will have good navigability, you have good results, good healing. So
I think we're out of time. I think it's been great presentations and fantastic discussion. Let me just conclude by saying that we are all very excited and continue to be very excited about the promise of bioresorbable scaffolds to return the vessel to its native state, to ungel side branches, hopefully improve long-term outcomes for patients. To do that, what we learned from the first generation Absorb program is that we need, one, better devices, and two, better technique that are really targeted for these scaffolds, which are different than metallic drug-eluting stent, with a little bit more reliance on imaging and more reliance on somewhat prolonged DAPT. And I think we're getting there. I think you've seen, I think Amaranth has been very impressive, the way they've been able to make increasingly thin strut devices while maintaining radial strength. So that's one of the major components to get us to more like early metallic drug-eluting stent safety profile, so then we can appreciate and realize all the long-term benefits of this technology. So we're headed in the right direction, and it's great to see so many interested people in the room, and I think we are entering now the next generation of bioresorbable scaffold technology. So thanks, everybody.